Good evening, everyone, and thanks for all of you to join on this weekend, sort of sacrificing some of your quality time. And we are here today to discuss about COVID-19 associated fungal infections, which, albeit the incidences have come down a little bit, both in terms of absolute cases of COVID-19 and also some of the fungal infection due to our prudence in the practice itself. But whatever patients we are now treating, most of them are on a prolonged course in the ICU or in the hospital itself. And a lot of secondary superimposed infections are giving us a trouble or interfering with the eventual recovery of the patient itself. So I think the topic is still relevant, and to uh, to discuss on this overall important subject, we have Dr. Shubal Dikshit from Pune Hospital. He's the Director of Critical Care of Sanjeevan and MGM Hospital, and he had been the ex-president of Indian Society of Critical Care Medicine. He had been in the ISCCM in every possible position, and he's taken ISCCM into greater heights. Welcome, Subal sir.
Thank you, Arindam.
We have Dr. Vatsal Kothari. He's the head of critical care medicine and also consultant physician in Kokilabai Dhirubhai Ambani Hospital, Andheri, Mumbai. Welcome, Vatsal sir.
Thanks, Arindam. Hi. Hi,
Yes.
Subha.
We have Dr. Shweta Shah, who is a consultant microbiologist and infectious disease, uh, also from Kokilabai Dhirubhai Ambani Hospital, Mumbai, a colleague of Dr. Vatsal Kothari. Hello, Shweta ma'am.
Hello, thank you, Dr. Arindam.
We have Dr. Sandeep Kadian. He's an intensivist and physician, along with pulmonologist in Asian Institute of Medical Sciences, Mumbai.
Hello, sir.
And we have Dr. Nitin Shinde. Did he join? I think he would be joining shortly. Dr. Nitin Shinde is a consultant internal medicine and infectious disease in Alexis Hospital from Nagpur. And Dr. Rahul Pandit is the Director of Critical Care of Fortis Hospital, Mulund, who would be joining shortly. I think Mr. Girish Arora wants to say something in his same hand. And I thank HCP Forum and Alnish to organize this event itself. The forum is an open forum, so I will come up with certain simplest of questions, and any one of the panelists, I will come to all of you. Anyone can answer, so none of the questions is directly specifically to any individual, so it would be a sort of discussion mode, right? Nothing very specific questionnaires that we have come to. So to keep it much more informal, but as well as informative itself. So with the first question that I want to raise is that the incidences of fungal infections among COVID-19 patients. So I will come to Bhattacharya sir first and know about his experience in Kokilaben, because they had been Mumbai and Maharashtra has seen if not the maximum number of COVID patients, and have treated a lot patients who have stayed for a longer duration in the ICU. Sir, your experience among the incidences of fungal infection in COVID patients?
Yeah. So, I mean, I don't have all the numbers with me. I think Shweta might be better at that. But what I can say is that maybe we had about 10 cases of mucor that we had diagnosed during the first wave. During the second wave, it went up by almost a factor of 4 to 5 times. Of course, the second wave is the time when the number of cases also increase exponentially. So, I think the number of cases also increased by 4 to 5 times as compared to the first wave. And definitely we found that, possibly because of the, maybe a inadequate understanding of the use of steroids in this COVID-19 disease. There was a lot of steroid usage during the second wave by physicians at various levels in the, healthcare structure. And that's what possibly may have contributed to the higher incidence of what we saw. As one was, of course, mucormycosis. We did see aspergillus also. We also say we saw quite a bit of pneumocystis carinii. So, that also being a fungus. So we do understand that, the way COVID has been behaving, it's been acting like an HIV, but in a much sort of a truncated time frame where there is an immunosuppression. Then we've got the utilization of steroids. Some of the patients are diabetic or have the diabetes unmasked because of the steroids. And so the immunosuppression, the steroids, the high sugars, all come together to produce, a sort of a favorable background for fungal infections to emerge. So that is what it has been our experience. And yes, I think that it is a problem that we're going to be facing further in the future unless we learn to kind of take care of the immunosuppression that we are utilizing in the treatment of the disease, which includes tocilizumab and itolizumab and other such immunosuppressive agents.
Right, sir. Is it only the mucor you are worried of, or you are also seeing a lot of pulmonary aspergillosis or your candida infection
So
itself?
we are seeing aspergillosis also, we are seeing candida also. And I think the patients who are very sick and who are kind of being in the ICU for a long time and who got a lot of invasive lines, they are also those who are quite predisposed to these infections. We are seeing a lot of candida auris. I think Shweta might know the numbers better, but about 10% of our, central line related bloodstream infections are because of candida, and about 70 to 80% of that is candida auris. And Oris is now becoming a very, very prominent organism, not only because it is very, very hardy and is able to survive on most surfaces and kind of even withstand many of the
Yes, sir.
antimicrobial agents that we use for topical disinfection, but also that it's developed over time, a sort of a almost a ability to evade most of the common antifungals. So we find that the echinocandins are the only agents which are kind of effective against Candida auris. So that's one of the other big problems that we are facing now in our ICUs.
Definitely, sir. I will come to that, but I will quickly come to Subal, sir, and then come back
Yeah,
to Madam about the KDA incidences.
yeah.
Sir, you had been privy to all the information from all over, not only all over India, but your friends from all over the world itself. So a very quick review of overall incidences of fungal infection in COVID-19.
See, I agree. Hello, everybody, and I agree with what Vatsal has said. Although the spectrum in Pune was slightly different, we did have a certain number of patients in the first wave, and the incidences of in my hospital about mucormycosis in the first wave were just we just had about 2 or 3 patients in the first wave. We did in those patients who were in the ICU for a long period of time needed invasive mechanical ventilation, those who had central lines, those patients who underwent a tracheostomy, those are the patients who develop secondary fungal infections after into the second week, especially in those patients who are diabetic and those who have been on steroids on a large number of days, and plus minus again those who have received toci or itolizumab. In the first wave we had only toci and itolizumab which was available. We did saw high incidences of candidal infections, candida auris and candida albicans in the first wave. In the second wave, of course, as what Vatsal said, there was a huge increase. The first wave lasted for about 6 to 9 months, but the second wave was a huge exponential for in about 3 months. And we had thousands and lakhs of patients which were there. Even the admissions in my hospitals were approximately about 3,000 plus in the 3 months of time. And we did have approximately about 25 to 30 patients who had mucor with the same incidences of candida infections, especially in those who are diabetic, especially in those who have been transferred from another hospital where they were intubated and they were brought here because they could not be weaned off or they could not be ventilated there. There was a higher incidences. After speaking to certain friends all across the globe, as far as in the Bangladesh or Nepal or in Colombo, yes, Sri Lanka definitely certain patients did have fungal infections, while as and so not much amount of mucor was seen there. Although in the second wave, what they had certain incidences of mucor and candida infections were seen. Although if you really discuss it with the American people or the European people, they did see, but they did not see such amount of mucormycosis. They were very surprised and they were very aghast to see the number of mucormycosis, what we really saw in India during the second surge. That is the overall spectrum. And I agree with Vatsal what he said. Basically, the indiscriminate use of steroids. Really speaking, the initial, also even the ICMR or the Ministry of Health also kept on, initially they had that, okay, steroids should be given into certain subset of patients. Then over on, they kept on modifying the criterias, and even certain family physicians, those who are handling the patients at the root level or even in the primary health center, steroids were used left, right, and center. Basically, it was mainly the inappropriate, indiscriminate use of steroid, which really unmasked diabetes, made diabetes uncontrolled, plus over and above topped up with a cherry with using immunomodulators also indiscriminately. Certain people, and I know of certain centers where indiscriminate use of immunomodulators also has been done. That was also one of the potential causes for precipitation and creating an excellent media for the fungus to grow and cause problems. I didn't see aspergillosis in my unit. I just saw two patients of pneumocystis which were diagnosed. But overall, those patients of mucormycosis, they definitely had a very turbulent course. They had a lot of turbulent course, and unfortunately, very sorry to say, certain patients who could not afford the treatment, they also had to stop the treatment in between because of financial constraints.
Now, I will come back to you about the risk factors and whether it is directly steroid or steroid-induced poor glycemic
Yeah,
situation, which is more important, right?
right.
So we'll come back to that discussion, but very nicely said. Shweta madam, very quickly about what Vatsal sir told about.
So I think Vatsal has done his homework well, and he has correct numbers. Uh, I wouldn't add on to what Vatsal said. I mean, I wouldn't change any numbers that Vatsal has given, but I would add on one of the another fungus or yeast that we saw apart from mucor and aspergillus and candida auris. We have fair number of trichosporon also, and that also is kind of a resistant bug, because even though it is sensitive to azoles, it is resistant to echinocandins, so that sometimes causes a problem. And just because we are talking about aspergillus and mucor, two things that I would like to add. So most of the times when a person comes from community with a fungal infection, it is going to be mucor. Sometimes in if it is hospital acquired, which is not very common with a higher level of hospitals, but maybe a second tier type of a hospital acquired fungal infection could be aspergillus, but mucor in the hospital is extremely rare. And I think Candida auris, there are two things about it. One, it comes in crops. So usually, if you have one patient and you've not been able to somehow control that particular bug, you will have another 3 or 4 patients surrounding it with the same infection, because it's very difficult to manage infection
To contain,
control.
yeah, yeah. Now
Yeah.
we'll come to that, madam. We have a very specific set of questions regarding the Candida auris, which our viewers will also like to know.
So the last thing about pneumocystis carini, the incidence we had was fairly high. Also, maybe because we are diagnosing it with PCR. So the
Right.
sensitivity of the test increases quite a bit.
Now, there is also a question regarding that, whether the incidents are related to the intensity of the diagnostic ability that we are doing, whether we are under reporting because of underutilization or under availability of the diagnostics test, because most of the fungal investigations are very specific and sophisticated, and not most of the hospitals do have that or cannot afford to have that. So we'll discuss that part also. Sandeep ji, your comment.
Uh, Good evening to all of you.
Good
I
evening.
practice in the Asian Institute of Medical Sciences, Dombivli suburb. So in the usually we see 1 or 2 patients per year of this mucormycosis in our routine practice. And in first wave, I have seen at least 5 to 6 patients. But in second wave, we have seen at least 25 patients of mucormycosis. And out of that, 3 had cerebral extension. Rest don't have cerebral extension. And also, I've seen a few patients which were very controlled diabetes. 2 or 3 patients which were very controlled diabetes, and they were post-COVID. They were not active COVID. And I've seen those mucor positive patients in those patients also. So it is around 25 patients, no PCPs, And also we are seeing increase in Candida infections also, non-albicans in ICU. The cause could be, as you have told, steroids, diabetes, and I also attribute it to the overuse of antibiotics also. More of higher antibiotics for more prolonged duration in ventilator patients.
Arindam, I'll just add
Yes,
one
please.
thing.
Yes, please.
Like I've also seen a few patients, those who are put into home quarantine, and they have been given indiscriminate steroids by the family physicians. Steroids have been given for 7 days, 10 days, in whatever doses. Simple, the absolutely asymptomatic patients have received steroids and antibiotics, what Dr. Kedia said. And those also certain patients have later on, once they have recovered from COVID, they have come back with uncontrolled sugars or new onset of diabetes and fungal infections. Absolutely normal CTs. CTs were done on day one. Also, sometimes even if they have not repeated the CTs, they have not seen any X-rays before doing, no lab was done, just steroids.
I have seen many physicians who have started steroids after their report came positive.
Yeah, that's what
The
exactly.
normal
Straight
CT and
away,
the
yeah,
minimum
yeah.
package.
It was it was thought that maybe steroid beginning.
Yeah, I agree with the
But
first wave. In the first wave, everything was new to everybody. First wave came up with 25,000 drugs. People even came up with all sorts of drugs were even considered for the use of it. But later on, as we gained experience, as we gained knowledge, definitely we could definitely fine tailor the treatment and come to accurate.
what could be the message, sir, very clearly that the steroid in certain subset of patients, not in the first
And only
phase, definitely not.
certain subset of patients, those who are hypoxic, those should be considered only very judiciously. That is very, very important. And not only that, you have to see that the sugar levels are adequately kept under control and not such high doses. They have seen cytokine storms receiving 1 gram of methylprednisolone. They are receiving 500 grams shot, even 120 milligrams 8 hourly of methylprednisolone. So everybody came up with all sorts of doses, which
What's
were
that, sir?
there.
Very quickly, your take on it. The days, which day should be an ideal to start steroid in a patient who is showing progression of the disease itself and becoming hypoxic?
I think that's a good question, Arindam. So I think what we need to educate the physicians, as my colleagues were mentioning, especially about the worry that there was an indiscriminate use of steroids at home, because physicians and other, treating practitioners have not understood that there are two phases here. There is initially a viral replicative phase, which is probably during the first week. And that's during the time when the body starts to produce the antibodies against the virus and the T cell responses, etc. And if the virus is not curtailed within the first week, that's when how there may even be antibody dependent enhancement, and there can be a cytokine, progressive cytokine amplification because of the monocyte macrophage system also getting activated. And that's what then follows in the subsequent week. So I think that in the first week, what is important is to try and curtail the viral replication by utilizing agents like remdesivir. And of course, if there is a significant rise in the inflammatory parameters, also looking at laboratory parameters like the CRP, the interleukin 6, looking at the ferritin, the D dimer, looking at the LDH. So, these markers would also tell you that, look, there is a mounting inflammatory response. That's the time that one would like to use the steroids. So the take home message would be that in the first week, if the patient is not hypoxic, if the inflammatory markers are not elevated, then please avoid the steroid, because the steroids are not some panacea that can be used against this particular virus or any other virus. And I think people have misinterpreted the study which has come from the UK, which had shown that dexamethasone is useful. And another study which came from also Henry Ford Hospital in Michigan, which we had utilized when we had started our protocols for steroids in patients with COVID when remdesivir was not available. So what we have to understand is the first week is the week where there is viral replication, and we should try to make sure that we are helping the body's immunity, not suppressing it. However, if the immune response is getting dysregulated, and I would like to mention about a condition called as antibody-dependent enhancement, where I had this particular famous personality admitted under me who had finished 2 doses of his vaccine, who came in with fever 2 weeks into after the second dose of the vaccine. On the first day, his anti-spike protein antibodies were 80 times the cutoff, and he had a very rapid rise in interleukin 6 and also in his CRP and inflammatory markers, and had to start steroids very early because
Yep.
just as we have seen antibody dependent
So
enhancement.
that's a very entirely, I think, in the maybe in the subsequent patients, we are going to a lot of patients like this who have completed their vaccines and coming up with
Yeah,
a
so what I'm trying to say here is
sir.
that basically in the first week, if you do not have a hypoxia which is progressive, or you do not have an increase in the inflammatory markers, then please avoid the use of steroids. It is more important during the
Do
time
you
of
do you favor, sir, very high doses of steroid, which are in sort of a lot of
no, no,
patients
no. I think
medical malpractice?
I think steroids are a double-edged weapon because on the one side you're going to be suppressing immunity, which can itself harm the individual. At the same time, you're also suppressing the very humoral and cellular responses of the immune arm, which is going to then overcome the virus eventually.
Yeah.
That's a name. Dr. Sandeep, yeah, and your experience of the duration of steroids. Why we are emphasizing, because the steroid seems to be the major factor in contributing towards the.
Usually I start steroids only in patients with hypoxia, not even in the raised inflammatory markers. Even I have not used steroids in the CT score of 10/25 also, if the patient is not hypoxic.
Okay.
Regarding
No,
duration, I don't give
and
more
the
than
question
7
is
to 10 days.
that how long you are using it.
Not more than 7 to 10 days, unless it is indicated for some other reason, septic shock like. So I usually prefer 7 to 10 days, not more than that. 6 mg
Subal
of
sir, your
Decta.
experience on prolonged usage of steroids.
No, I've not used it for prolonged duration. I've used it only for a maximum days of maximum 7 days. Usually, I have to stop it on day 5. On day 5.
Do you like to taper it off, or if you are
No,
using
I just stop it abruptly.
abruptly?
I just stop it overnight. Just
Vatsal
abruptly.
sir, is it linked to a clinical recovery? Because a lot of, particularly pulmonologists, they are putting an analogy like your cough, right? Organizing pneumonia, where they use steroid for a longer duration. Particularly patients who are in prolonged COVID, not showing signs of full recovery with a continual lung infiltration happening. In those certain
Yeah,
cases,
I think that's a good question, Arindam. See, I do agree with what Subal is saying and Sandeep is saying, that look, try and restrict the use of the steroids so that we don't bring about the emergence of the fungus and other kind of unpleasant infections like Acinetobacter, Klebsiella, etc. But at the same time, one also has to look at if there is a very severe inflammatory damage to the lung, and there is a significant fibrosis which is coming in. I mean, you look at the exudative and then the fibroproliferative phases of ARDS. The fibroproliferative phase is very, very evident, and there is a lot of fibrosis ensuing. I think then one may have to consider a low dose of steroids for a little longer period of time, because I have seen terrible complications with many of our patients who have survived the initial COVID injury, but then have landed up with terrible fibrosis, terrible, barotrauma, and ventilator-induced lung injury, and then have languished on ventilator for months because the lungs are so severely fibrosed. So I think somewhere we have to strike a balance where at the same time we don't want to suppress the immunity and worry about Candida auris and Aspergillus and Mucor and Pneumocystis carinii. And at the same time, we also want to make sure that we try and suppress the fibroproliferative response so that we don't land up with a damaged lung and we can't get our patients off the ventilators.
right. So with all of your permission, I'm just showing you certain a very Indian data on the incidences of your fungal infection in COVID patients. Is the screen visible to all of you?
Yeah, it is visible to
Yeah.
me. Yeah.
So this is the inter-kingdom interactions. This is the fungal infections that might happen in a COVID-19 patients if we are not aware, right from your candida, all the different albicans and non-albicans. Aspergillus, what they have named is COVID-associated pulmonary aspergillosis kappa. Mucor, which they have named as the CAM, COVID-associated mucormycosis. Coccidioides and Cryptococcus, very few. Pneumocystis, which Shweta madam said, is if we are really looking into it, we might find And the problem with both aspergillus and pneumocystis are that the imaging, particularly in an X-ray, it is very difficult to differentiate between actual native corona infection and a pneumocystis, or at times the your kappa itself. And some of these, and very interesting, a lot of trials or case reports that have shown that the Saccharomyces, particularly with the connection is with the use of the probiotics that we use, econom sachet, because a lot of our COVID patients do present with diarrhea, and our immediate knee-jerk reaction is to use probiotics. And remember, these patients are, most of us in the ICU would be on immunomodulators, and they are using live this sort of probiotics in a immunocompromised patient can lead to sort of opportunistic infection itself. This is the ICMR data that has come up very recently, and they have done it in 10 tertiary care hospitals, both private and public, including All India Institute, then your Gangaram Hospital, from one of the hospitals in Mumbai. I forgot the name, most likely KGMC or something. And this is the secondary infection in COVID-19 patients. The overall infection rate was pretty high. And as expected, the bacterial infection was the majority, right, gram negative. And along with, if you see the Aspergillus candida and other fungi, which is not also bad. So if you see, this is the overall 72% of the overall infection were gram negative, but the fungal infection was in and around 6 to 8%. And fungal and there were co-infection with fungal and gram negative in 4% of the patients. And these were the site-specific etiological diagnosis of pathogens. As long as the Indian data is concerned, this is one of the most extensive and robust data that has been published. And you can see, yeah, the fungal infection, candida, most of them were either in blood or in urine, and maybe in some others. Respiratory specimen, very few. Normally, we do not treat candida if they are in a respiratory specimen. I will have a specific question on that with the Sweta madam. Aspergillus, mostly all of them were reported in the respiratory specimen, and others in blood and urine in others. So overall, this is what looks like on a name. And this is yeah, please. And this is on a tertiary care hospital in India, a case series about the mucormycosis. This is from the All India Institute, and they have shown the mucor both in not only in the orbital scene, but also in the pulmonary and also in the cranial mucormycosis, right? And they have shown that obviously most of the patient expired, and the length of stay was much longer. So this is the mostly that this 13 patients they have come up across with. Any comment on overall? And
yeah, so I would just like to make one comment. I think Arindam, which you had shown in that previous slide. So we had this one gentleman who had an MDR tuberculosis. He was a diabetic, and who had also then initially lymph node tuberculosis, then developed tuberculous meningitis. He was admitted with us. Then he developed COVID disease. And post-COVID, he developed severe cryptococcal meningitis, very severe cryptococcal meningitis. That is something that you have to keep in mind, that you can have a non-HIV associated cryptococcal infection following severe COVID disease, along with associated diabetes and the use of steroids.
Okay. Sweta ma'am, any comment on the data?
I think all the hospitals will have very, very similar data, more gram negative than fungal and GPC and co-infection. So I think that is more or less similar at every center. And cryptococcus, I mean, we didn't grow except for this patient, I mean, not in blood and all, meningitis only, but we have had friends in India who've grown cryptococcus in blood and other body fluids also, I mean, the tissues also, lungs and all.
Okay, I will have a very two definite introspective questions to all of our senior panelists. One is that is this higher incidence is due to the surge capacity, where we too much occupied with too many patients at a shorter time span, a lot of patients coming put together, where our capacity to handle, particularly on the terms of infection control and all others, and maybe we were searching for a lot of holy grail, used a lot of steroids and immunomodulators. Do you think that is one of the major contributors towards a higher incidence of any sort of fungal infection? I'll start with Sandeep ji and then come to Vatsal ji and Suval sir.
Not really related to the higher number of patients. It's because of mostly because of steroids and diabetes, and maybe because of overuse of antibiotics, more higher antibiotics, and for prolonged duration. Because on giving higher antibiotics, your normally vectors fluoride suppressed, and you tend to grow fungus in blood
Right,
also.
right. Vatsal sir.
Yeah. So I think that basically let us understand that COVID itself leads to a dysregulated immune response. Okay.
Right,
And
sir.
COVID itself is immunosuppressive. If you have severe COVID, I think if all of us look at our hospital data, we will find that these patients keep on languishing and getting one infection after the other. This may not necessarily be related to just the steroid use or the immunosuppressives like tocilizumab, etc. But the COVID itself causing a severe, because any severe immune response gives rise to a compensatory immune suppressor
Right,
response because the body
right,
is trying to, dampen down the immune response, which is itself causing damage. So COVID is one. Then, of course, the use of the steroids unmasking the diabetes. Okay, and I believe that COVID itself causes an endothelitis. Because severe COVID. So that also
right.
itself, because of the injury to the vasculature, can then predispose to the growth and invasion by these fungal organisms. So I think that it's basically that, yes, COVID definitely caused an upsurge of infections. And with the immune suppression that followed, the fungi and other opportunistic pathogens had a gala time.
But I would definitely focus on that point, because a lot of research are coming that how COVID is altering our immune response to the normal person can do it over a bacterial or a fungal infection. A lot of trials have actually, the reports have come up that it is definitely showing that COVID is altering the immune response to standard pathogens. Subal sir, your comment.
Yeah, I agree with what Arindam, what you're saying. Definitely, COVID it produces a big amount of immunological disturbances at the same time of direct affection of the pancreas also. I've also seen certain patients who have got those are non-diabetics who have come in with high sugars even prior to the use of steroids. So it's been possibly also related that COVID itself suppresses the production of insulin, and therefore the sugars go up. Plus increase in the indiscriminate use of steroids, what we discuss, and also unmasking of the diabetes in those patients. Definitely, it was an increased incidences of secondary infections, and over and above that, more importantly, indiscriminate use of antibiotics. Not all patients required antibiotics. Secondly, also those patients also were given high dose of higher antibiotics. There were also certain patients also received meropenem along with imipenem right from day one, just because they had lung lesions, so that secondary infection should not occur. And over and above, certain patients also received again immunomodulators, all different sorts of immunomodulators, all maps were used. So that was the main reason which actually precipitated the whole produced the whole cycle of responses, and therefore we landed up into problems.
In
That's what
Being
fact,
I
in
feel.
Arindam,
the
I don't know what
yes,
is your experience, but
yes, sir.
during the first wave, especially when there was so much of fear about this virus and the PPEs and those protocols and the worry about aerosols, I'm sure that infection control practices were not optimal,
Yeah,
and I think that
Yeah,
also would have really.
I will ask this question to Shweta ma'am rather. Do you
I
think
agree with
there were,
Watson.
yeah, do you think there was any uh, sort of inadequacies or any strategically or manpower wise or due to the surge capacity that our infection control practices cutting across all over the country were a little inadequate, or we were not very prepared for this sort of the patient rush, whether that contributed also?
So I think I would put it this way. It was not just the patient rush in the second wave. I think it was, I agree with Vatsal, in the first wave itself, we had problem because we are not used to wearing those big suits and look after the patients. One, to everybody was so scared to even touch the patient at that point, first wave. I think in June itself, we had Candida auris outbreak in our COVID ICU. We had, I think, 3 patients almost together. That's when we started sending our nurses more frequently because nobody was going only to check. We actually figured out that the cleaning was not being done as per we had hoped to have. And the
Right.
same situation, as you have been saying, reoccurred, even though we knew these are the problems in second wave, because there the capacity, as you have mentioned, was very, very little. Meaning the all of suddenly the pressure was so high that then we were inadequate in manpower, and then people were kind of they knew that it doesn't matter. So I think we have had terrible experiences off and on, although we thought that we were really looking at it very closely, but we have had our inadequacies. And I'm sure that most of us in all the hospitals have had period where, things just slipped away out of the hand, unfortunately.
Okay, we have a question from
I just want to
Udaya.
comment
Yeah.
regarding the severity of illness. Now, we have seen most of the mucor patients in the mild to moderate category and less so in the severe category. So I have not seen much patients of mucormycosis in severe cases of COVID who are on ventilator or who have bad lungs. Mostly I have seen the cases in the mild to moderate severity only. This
In
is my
fact,
observation.
I think I would extend it further by what Subal had said, that many of these mild and mild to moderate cases were being handled at home. If they were being given the steroids and they started developing symptoms of
You are not,
mucor, they were not
yeah,
being monitored. The
monitored.
sugars were
Yeah,
not being
that's the
monitored. They
question.
may have
Yeah.
had some tooth pain, they
So
may have had
that
some
could be,
sinus pain, and they just ignored it, until it kind of flared up and then created
Yeah,
problems.
But
that was
somehow
actually
we
the
had
problem.
but
Arindam, see, the
somehow we had
basic
very
yes.
severe patients on ICU also, and we are doing CT of the ICU patients also. But the incidence of mucormycosis in severe patient was much less as compared to the mild to moderate patients.
Correct, because there is much more intensive monitoring of the severe patients and their sugars and auditing of the medications, and also
absolutely.
probably that also keeps things
Yeah,
under
yeah,
control.
and absolutely in those patients who are kept into home quarantine, see, certain hospitals did have certain softwares to monitor them. Certain hospitals also developed certain infrastructure and created certain group of doctors from allied medical specialties to help them. But unfortunately, the certain family physicians or certain physicians who are at the who are handling them on their own without a hospital backup, they never had a follow-up of those patients, or they never kept a track there. Even the patients did not know what they should monitor. They were not told that a 6-minute walk test needs to be done. You monitor for saturation levels, watch for the temperature. Unfortunately, that was the
But most importantly, that the sugars were never included into the
yeah,
monitoring
yeah,
system
and
at home
Absolutely.
base.
more
Yeah,
importantly,
home
more
sort of.
importantly,
Correct, correct.
never, even basic investigations were not done. Basic investigations were added even into a category 1 or mild symptoms. Even if you really see the Ministry of Health protocol, they have said that HbA1c, sugar levels, HIV levels need to be done into each and every patient who is admitted to the hospital. So unfortunately, that did not happen, and that's how actually the sugars went
Now, I
haywire.
have very curiosity about it, that we had seen so many of diabetic patients. We have seen in many different subset of patients. We have used steroids. Even in the first wave, albeit the numbers were less. But how come the mucor popped out of nowhere? What do you think? Is there any truth or any basis of that the oxygen supply or inadequacy in the maintenance of the oxygen delivery systems or appliances? Was there, or some in this, the variant had created something in our immune system so that the mucor got an entry to it?
See,
Are there
somehow
I,
I
any
feel
factors?
I look
sometimes.
at it this way, that, I think given our population density, given the amount of garbage around, I think I feel that, probably we are exposed to more mucor than other countries where, the population a little more
The
distributed over a
ubiquity is
larger.
more, yeah. The
So that is one.
presence
So I
of
think
mucor is more in our.
we're just exposed to more mucor. That is one. Yeah. And two is that obviously, given in a situation like this, where we are going to be having so much of immune dysregulation and then, sugars going all over the place, it is not surprising that mucor is going to stand up, because it is a ubiquitous thing. It's all over the place. I'm sure I have it in my nasal passages, or maybe in my upper respiratory tract, but it's my immune system which keeps the mucor under check. The moment that immune system is getting dysregulated for all the reasons that we have mentioned before, the mucor is going to stand up. And I think given India with its, everything is densely packed. I mean, you have 1.3 billion people in
And
such a
maybe the
small area.
incidents have come down now. It proves in retrospect that with a better awareness and a better control of the sugars that we are doing it, and a more cautious use of steroids, particularly in critically ill patients, that's how we have been able to reduce the incidence also. Subal sir, you are saying something.
No, more importantly, see, as and when the numbers cropped up, as and when the numbers went on increasing, definitely certain amount of infection control policies also went for a toss. You cannot deny that. Definitely, as far as possible, all intensive care units were taking utmost number of care. Number of patients also increased. Yeah, like even in my hospital, we were told to create more number of beds in one cubicle where were supposed to keep one patient. We were instructed to admit two patients into the cubicle. So it's bound that over a period and above. My ICU is 25 beds. We were instructed to convert that to 50 bedded ICUs by converting rooms. Certain rooms were actually no ICUs, so there were no ICU patients were supposed to be there. We definitely admit such critically ill patients. So therefore, the environment plus also additionally the loss of the proper infection control policies and techniques, they were also equally important, and of course
Now
steroids and
we take that
immunosuppressants.
cue, sir. On behalf of ISCCM, we are initiating a project on the first week of August where we will look into the first 6 months of admission and the overall bed occupancy, bed utilization, device utilization, and we'll try to link it up with the incidences and the outcome of it. Whether what we are thinking that with a very high bed occupancy, turnover, and the device utilization, were there any changes in the incidences of infection or outcome of the patients. So this definitely we are presuming it, but maybe at times we have done a very heroic work and we have come up with a better outcome also, and in that way. So we'll do that. It would be all the centers would be voluntarily joining our ambitious plan with both ISCCM and CAHO coming together, that we will have at least 300 hospitals joining and sharing their data in retrospective data. And we'll try to find out what was the outcome of the Indian critically ill patients during the second
and
wave. Yes,
and
sir.
secondly
I
again there
have
was a mutation. May I think Shweta will agree that the second wave definitely in Bombay, Pune, definitely there was a mutation which was there.
It
Yeah,
was,
Though
Shweta madam.
it would be the Delta variant.
yeah,
It
it's a
would,
Delta variant. So there was
yes.
that was a Delta variant. So the second wave was a mutated Delta virus, which actually caught affection. And unfortunately, the swab was sending, they were just coming in as positive. Only certain tertiary care hospitals, like say Vatsal's Hospital or Hinduja or bigger hospitals, they were had the luxury to do a genomic sequencing further. So that was equally important. So it was the second wave was a Delta in actually
Shweta
Maharashtra.
madam, yeah.
Yeah, so I'm sorry that I'm going back, but there are a couple of things that in the discussion I would like to add. One
Yes,
is
please.
the fungal spores. So fungal spores are ubiquitous, as Vatsal also mentioned, and they are there more in the so-called villaging or rural area and less in urban. However, vis-a-vis rural to urban, wherever the construction is there, there will be a lot of spores. So most of the times mucor will happen in more open area and not really in the hospital because the environment is more controlled. However, all of our hospitals and residential places and road in urban area will undergo construction, and there will be
Well,
no
aspergillus.
manageable things there, and that is how aspergillus will happen more in the closed spaces and more in urban area. So that is about the environment of fungi. The second thing I wanted to tell about the virus or the mutation. So when the virus is multiplying very fast, which happened in the second wave, that is the time it will actually undergo mutation. I mean, that's plain simple logic. So if
Right.
we have less number of cases, we will have less number of mutations. So I'm sure I completely agree that Delta variant was the reason, even with us, where Mumbai, Pune in the second wave, which must have really caused the trouble.
Yeah.
Okay. Dr. Pandit has joined. Welcome, sir. You must have a
Good
lot.
evening.
And thanks for joining in. We have had certain discussion to update you that mostly
Sure.
in this first part of the web series of corona associated fungal infection. Today we are mostly discussing about the incidences, prevalence, what type of fungal infections, what are the predisposition, risk factors, strategies mostly. We have not gone into the treatment, which would be mostly in the second part. So, and you have come up with a very nice paper actually, where you have come up with a strategy where you can almost put mucormycosis into a zero incidence. Can you please share that with us?
Thanks, Dr. Khan. Nothing misses your vast reading capabilities. Yes, we actually published a paper 2 months ago um, where we looked at the incidence of mucormycosis in our group of patients. And around 5,400 patients approximately, of which 1,027 were from intensive care and rest of the patients were from the wards. We had a very clear understanding that the patients we followed up for at least 2 to 3 weeks post discharge, we only take up those patients. So approximately 5,200 patients came into that category. And we had zero incidence of mucormycosis right from the start of pandemic. Not one case of ours actually had mucormycosis. And I think the reason which I attribute, which probably was the main single most important reason, was that we had a very strong glycemic control, which was nursing driven. Very, very strong glycemic control. The second was that we hardly used steroids in a bigger dose, right? We had a very straightforward strategy of never to go more than 40 milligrams 3 times a day, if at all we had to give, which was once a day for bethylprednisolone, and then it would be down to 40 BD or 40 OD. That was the maximum. No pulse dose, no high dose, no long dose, 10 days and we stop. Third thing, only 67 patients out of the 1,027 in ICU actually received any form of MABs. That was in the first few weeks, and I am one of them. Actually, I got the MAB. So I am one of the things, one of the person who was given a monoclonal antibody tocilizumab. After that, we realized that it actually is causing more infections than any good. So we stuck on to the basics of critical care, ARDS management. We would be very proactive in intubating patients if required. Almost 40%, 35% of our 36% of our patients were intubated. We've got the other paper also accepted in IJCCM, should be out in publication in a few weeks time, hopefully. And I believe that if you have a strategy of controlling the sugar, if you have a strategy of limiting the dose of steroids, and if you have a strategy of having a nursing driven protocol for sugar control, you probably will be able to avoid mucormycosis altogether. If you look at the incidence of mucormycosis, there was another paper published just before our paper, which looked at all the cases reported across the globe for mucormycosis. 80% of them are from India. And that was by Professor Mishra and Professor Shashank Joshi. And it also looked at another aspect which it looked at was the incidence of diabetes in these patients was 88%. So I think there is a strong correlation between sugar control, diabetes, and diabetes control in mucormycosis. The rhinocerebroorbital mucormycosis which we are getting is typical of diabetes. We have other mucormycosis which we fortunately haven't seen. Having said that, just last week we've reported one case of mucormycosis, which is gastric mucormycosis, which was the diagnosis, which was the first case in our patients. This guy got better, came back to us with a GI bleed when when a gastroenterologist put in a scope and looked at the mucosa. It looked as if the mucosa was completely eroded out. It took a biopsy, and the post-biopsy report has actually come as mucormycosis, but it's not showing angioinvasiveness. But it still doesn't matter. It is mucormycosis. Essentially, that's the first case of mucormycosis we found last around 10 days ago. So that's been our data.
Oh, that's
Just to ask you, I'm sorry, Dr. Arindam, just to
yes,
confirm,
please.
what I'm understanding is you're talking about your patients not getting mucormycosis. Am I correct on this?
That's
But
correct.
you might still have somebody else, some other patient coming straight away with mucor to your hospital.
Of course. So there were plenty of them who came to us. So those patients who came to us for COVID-19 management, none of them actually had mucormycosis,
Got it.
but we had several of them who came for mucormycosis management.
Sure.
So I have a
But
question, Rahul. We know that iron can predispose to, increase in the incidence of mucormycosis. Have you found any sort of correlation with zinc? Because there's this whole concept that giving zinc to patients who've got COVID, is supposed to help as an immune booster. But can zinc itself act as a sort of an adjuvant in increasing the
Yes.
growth of mucor?
There are at least 2 papers to that effect, which talk about it. Zinc actually worsening the incidence of mucormycosis. There is also a fact that these patients were hypoxic. They were probably having high sugar. So there was an acidic environment in the local mucosa. There is something called the viral syncytium, which can form, which can actually predispose these patients to become prone for opportunistic infection. It's not necessarily to mucormycosis, but that seemed to be the most opportunistic infection we have. I was speaking with the Commonwealth guys this morning. I had a meeting with them, and we were talking about liberal versus restrictive oxygen strategy, and mucormycosis came for discussion. Even our neighbors, there were people from Bangladesh, from Pakistan, from Sri Lanka. There were people from Japan, China, Hong Kong. Nobody has seen the number of mucormycosis cases as we have seen. I was especially surprised with Bangladesh. I can understand Pakistan is probably on the bit of the northern side where the climate may not be that tropical, but Bangladesh, typically a tropical country, as probably as much as India. I would not say the soil of Bangladesh is any different to what we have, because we have mucormycosis in our soil. The Singaporean guy talked about melioidosis and presence of Burkholderia pseudomallei in their soil, which is again a known thing that the tropical countries have a higher incidence of that. But mucormycosis seems to be sort of in the Indian subcontinent, that too in patches. You don't see it across the country, you see it in patches.
I think I would just like to mention about, because I think Rahul mentioned about GI mucormycosis. We had this one patient who had, we saw quite a bit of COVID associated ITP. This guy had COVID, he developed ITP, he developed thrombocytopenia, he developed GI bleeding. He was given a lot of steroids. Then he had a duodenal diverticulum. He bled into the diverticulum, which got infected by mucor and finally it invaded into the vessels out there, and he had a perforation, and then we had to operate, and finally he succumbed. So,
so,
This
mucor.
is the first
do you
wave.
think, Vatsal sir, just 1 minute, ma'am, do you think that a lot of GI bleed that is happening, it is escaping? Maybe there is a GI mucor also could be a possibility, because last week we had also a cecal perforation and there were no other uh, sort of we have sent it for the mucor analysis, but
I think
it,
you'll have to do the histopathology, but yes, this
yeah, yeah.
definitely was one of the cases where we proved that there was GI mucormycosis, which finally killed the
I
patient.
think this is going to be the next thing, that would be that maybe a GI mucormycosis is escaping our diagnostic ability. Madam, yeah, you were saying something.
So I was just saying that this patient was after the first wave. It was in the just much before the second wave came in, what Vatsal was talking about, the diverticulitis patient. And after that, after second wave also, we have had a couple of GI mucor and even renal mucor.
But Dr. Pandit sir, is that do you think a lot of people are not only doing a nurse-driven your intensive insulin protocol or something? A lot of people are adding a longer acting like Lantus or something in way, so that not only the numbers of are less, the glycemic control is good, but there is lesser amount of variability also. Do you think that's
Yes,
a good strategy?
I think it's a very good strategy. I believe that you need to have a steady state of glucose. You don't want fluctuating levels of glucose. And if you have a person specifically who is eating and drinking on his own, it's better to actually have a steady state insulin with a longer acting insulin going in. But patients who are unconscious, patients who are being fed through nasogastric tube, I would be a bit worried about giving them long acting, especially those who have been sedated by us. The least that we don't want to miss out hypoglycemia and then keep on having hypoglycemia for the next 14 hours because we gave them a long acting dose. So we need to just be a little bit worried about those patients who are completely sedated.
And, Dr. Udaya is trying to ask a question. Can you please unmute and ask the question directly? response. I think not.
Maybe it's by mistake that his hand has come up.
So Rahul, you had mentioned about oxygen. My understanding is that oxygen, high amount of oxygen actually inhibits the growth of mucor.
That's correct. That's
And
both are true.
and I'm not, and I think mucor thrives more in a dry environment rather than moist environment. So I think moist oxygen is probably going to be inhibitive to the growth of mucor rather than encouraging it.
Look,
And what also Madam said is that mucor happens more in the open area. So maybe and in the hospitalized patients more of an aspergillosis. Dr. Pandit, your comment on this?
I think you are all three of you are right, Shweta, Vatsal, and Arindam. I completely agree with you. So let me talk about the oxygen and the humidity and the moisture and humidifying oxygen. When we give it through that flow meter, when you're there on the nasal oxygen, you are actually giving agitated you're giving oxygen through the water. So you're agitating the water. That agitated water will not grow anything. Forget about mucor. It's not going to grow any organism because you need some standstill water to sort of things for it to grow. Now, microbacteria could grow, but not mucor spores, which are not going to grow across there. If you're giving it through a humidified circuit in a high flow nasal cannula, BiPAP or ventilator, then the temperature is fairly high for it to actually give you a humidified circuit. Again, I don't believe that you will be giving mucormycosis through that. So this whole theory about oxygen causing mucormycosis,
or even sometimes use of industrial oxygen.
Yeah, industrial oxygen. I think it's all, and I've spoken with people as good as Anjan Ray, who are really very, very highly accomplished scientists in the country. And he was very clear that, in fact, industrial grade guys are even more worried about the purity. The oxygen percentage may not be 99%, but they really want to see that it's pure oxygen because they're making steel out of it, making other things out of it. So they are also equally worried about purity. So the purity is actually not a problem. I again come back to the same thing: overuse of steroids, poor glycemic control. See, Arindam, we are on a tip of the iceberg. All 5-6 of us who are sitting are coming from institutes which have got multiple support systems. Most of the mucors actually came through from the hinterland and from the interiors and smaller hospitals. And it's not that I'm blaming them. They were just outnumbered with the patients. How much could they do? They were actually trying to look after the patient as much as they could to the best of their ability. But they just could not keep a tab on and pulse on all the things. They did their best. And unfortunately, this is what happened.
Definitely, yes. So we have a clear understanding that what went wrong and how we could rectify, how we can reduce the incidences of the fungal infection itself. Very quickly, I will ask Shweta madam, and rest of the treatment part we will take in the next part of the webinar. What would be the diagnostic workup? How we can diagnose quickly in this way?
I think now we have kind of agreed that the first thing should be KOH mount, and usually KOH mount takes only half an hour and it doesn't require huge equipment or something, just requires plain microscope. The only problem with that is that you require a trained eyes, and that is where you might miss even if the fungal hyphae are there, because it's not very easy to see fungal hyphae in KOH mount. The better thing, if you have the facility, you can do is use the fluorescent microscope, because you have dark background and you have fluorescently illuminated fungal hyphae, so the things are easier. But that is also not available in all the hospitals. In fact, it may be available for tuberculosis, but the filters for fungi and tuberculosis are different, and fungal, as we know, was always last thing to be learned or to be diagnosed. So most of us will not have fluorescent microscope for fungi, and culture so far remains gold standard. But the best of the eyes with microscopy and culture only will be able to diagnose up to 550 to 70% of mucor. We still will miss about 30 to 50% of mucor, and some will be get added with histopathology. But it is bound to not grow, because it is very, very fragile type of fungus, and if there is another fungus growing, yeast growing, bacteria growing along with, they're going to kill by their toxin to mucor. So it's very difficult to grow the fungus in the lab. And that is it we have in our armamentarium. There is nothing else. We've tried PCR for some patients. However, PCR comes with its own problem in terms of you don't know whether it is invasive or not invasive. So this is it.
Regarding aspergillosis, madam. Kappa.
So aspergillosis, the other thing you can do is galactomannan. So, and you also can do BDG, and those
Yeah.
work very well. But again, you have to have a very, very good microbiology lab for that, because it requires a special treatment area. It's as sensitive or prone to contamination as any molecular lab. So, however, but if your BDG and galactomannan both have negative, it most probably is mucor. That is how the negative predictive value will work. But the biomarker are extremely, extremely good tests.
But it could have some false positive also. So you are
Yes,
saying
yes, that is what is. It is very
negative,
prone to
more negative
contamination,
predictive
and you
value.
will have false positives. So you have to have
Any
extremely good
any
lab.
any problems with the diagnosing candida? Any issue
No,
that you want to mention?
no, that is the only
Or
thing which grows easily, and you can easily grow candida. However, identification is the issue, because candida auris usually gets missed by most of our automated system also. So
right.
till say 5 years or 4 years back.
So to make it easier for the viewers, so a standard blood culture with a good amount of blood in it will grow a candida, but you have to be very careful about not missing the species itself.
So good amount of blood would be about 1 ml per kg patient body weight.
Yes,
That would be about
that's the
60
point.
ml for a normal patient, and what
That's,
we usually get is about 15 ml per patient.
that's a big volume.
It is.
Microbiologists are very demanding now. Can
Finally,
I
the
ask
time
one
has
question
come.
for you? Can I
No,
ask a
but that's a,
question to you?
Yes,
but that
Arindam,
is,
is that okay?
Shweta,
Sorry.
Shweta,
Yes.
do you recommend that, or in the fungal culture form, have you included in your hospital that you should send 60 ml of blood? Or
I
you think that it should be included as a part of protocol so that the yield is better?
So normally what we recommend is paired blood culture, and if you have a line, then at least 2 sets. I have not still so far reached to 60 ml. I'm trying to reach to 40 first. So two pair of blood culture if patient has a central line or a PIC line or something, one peripheral set and one central set.
I think
Okay.
20 to 30 mils you get easily, isn't it? Most people will
Yeah,
send 20 to
20
30.
ml. Yeah, even 20 ml is fine, but 60
Yeah.
was something what I
Yeah.
was
But
But
surprised.
that's the
that is the
recommendation. That's the
recommendation. 1 ml
recommendation.
per
That's the
So,
patient.
recommendation. Yeah.
yeah. Because
In
it's
fact,
inoculum based. So I have one question for Shweta. Shweta, a very simple question. Maybe I am wrong, but mucormycosis specifically, because it's not sort of something which grows into the blood, it sort of does not go through the lines. It's not a catheter associated infection or something. So does it require a breach in the mucosa for it to actually start infecting, or it's not necessary?
Um,
So would the
breach in the
repeated testing,
mucosa, yes.
would the repeated
Rhinocerebral
testing
breach.
for
Rhinocerebral breach will help it tremendously, and probably yes, I think the micro invasive, so it the spores uh, will be taken. Epithelium, the healthy epithelium will not allow the spores to enter. That's absolutely correct. But any infection or any
the
breach
nasal
will help.
crusting which they had with the oxygen, dry oxygen going in, maybe
Yes,
the
yes,
repeated
yes.
RT-PCRs which people were doing to test, get themselves negative, maybe all of
Could
that
be.
actually eroded the mucosa. Interesting.
So also, if we remember the endothelitis that Vatsal spoke about, which is because of the virus itself, will help. One thing we've not spoken about, we spoke about zinc, but we've not spoken about the iron, because there is an iron overload in the patients, and mucor itself loves iron. It's angioinvasive. So that is considered as one of the important factor, apart from the sugar, steroid, and endothelitis.
I don't know, this high ferritin levels which occur in
The same thing.
inflammatory states,
The
whether
same
that
thing.
also is kind of giving some iron to the mucor and allowing it to grow.
It might be helping is one of the PGI paper.
now, if you and are there any PCR based tests for both mucor and aspergillosis, madam?
There are. The
But not
so
that much of availability, right?
I so no. Let me first talk about how useful they are.
Right.
They are useful in terms of finding out whether mucor or aspergillus, but you will have to run two PCR separately, one for aspergillus and one for mucor, because
Right.
they are different tests.
Right.
And the other problem with the thing is that when you take, say, rhinocerebral tissue, You don't know if mucor or aspergillus is present. You don't know whether there was invasion or not. It could be just a colonization, which is quite common. So if you take a lung biopsy and identify mucor or aspergillus by PCR, you are quite sure on your diagnosis. But with the swab or rhinocerebral tissue, you might not be. Cerebral, yes, but basically the superficial tissue. And the cost, because we are not using it, is right now very high. However, all the lab now, since can do RT-PCR for COVID, any lab at this point will be able to do aspergillus and mucor PCR. It's just not difficult. It's the utility of test has not been very
And what
good.
would be the sample? What would be the appropriate sample of doing it?
Tissue
The area
biopsy.
of concern, yeah, for the PCR.
Tissue
With a
biopsy.
tissue biopsy.
And deeper, the better. So that is where the problem is.
So you need a very nice representative sample where you can do a PCR or a culture or a direct microscope. So these are your. But tell me honestly that we all are working in a tertiary setup. How well these are available in a smaller tier 2, tier 3 cities?
So again, the same thing, because now RT-PCR machines are available in second tier or even third tier cities, because they are now available. This test now can be done, but people will have to have the reagents available there. It was very difficult for me to even validate the test. It took about 2 months for me to just get the kit, even if, when we were ready to pay. So the government push is required. See, a year back, we did not believe that every center can do a PCR. So huge push is required there.
Definitely. Okay, so we would come to the closing part of the session, where we will come back again to after 2 weeks, after a week or 2 weeks time, we'll inform you, and we'll discuss about the treatment strategies. We discussed about the preventive and diagnostic strategies. So before closing, we will ask every one of the panelists to give a closing remark. We'll start with Sandeep. If you may please give your closing remark.
So now the cases are declining. In the last month, hardly I have seen one patient. So probably it has to be related to the COVID infection mostly, because previously we used to see very few patients. So I don't know what is the relevance after 3 months of this discussion.
Okay. Definitely. Okay. So I will come back to Subal, sir.
My first most important thing is don't neglect any symptoms. Diagnose COVID early. Don't just follow a doctor. Don't use steroids indiscriminately. Use steroids only in hospitalized patients, those who are admitted to the ICU, and very rigid control of sugars. That's very important. And don't neglect any symptoms, especially those who have got like burning eyes, facial pain, tooth pain, or any kind of sinusitis or epistaxis. Do not neglect and rule out fungal infections.
Vatsal, sir.
Yeah, sorry, I my laptop had conked off. I missed the question.
Yeah.
What is the question?
There's a closing remarks.
Take home message, Vatsal. Your take home message.
Okay, so take home message is first to understand that we are dealing with a virus which is mutating. Yeah, that we're still going to be facing problems in the future, that we need to be ensuring the fact that we continue to try and prevent the infections rather than dealing with them. And as all of you have mentioned, then try and keep the immunity at a optimum so that and you don't suppress it so much that the opportunistic pathogens stand up.
Shweta, ma'am.
So I think I'm going to take this chance. I believe that the audience and the speakers, everybody is intensivist or ID specialist. So I'm going to take the chance for infection control. Most of you all believe that infection control in your unit is the nurses or microbiologist's job. If you have a microbiologist, most of you don't even have that. So please make it your, or at least your resident's job. I mean, that will make a lot of difference.
Yes. Yes, that would be very nicely said. Yeah. Pandit sir, summarize and give a very, it's your punishment of joining late.
Thank you. Thank you. Look, I'm sorry I joined late because I mean, you know that I do a Marathi program on
Marathi
COVID awareness every Saturday. But
Right,
I'm
sir.
now thinking of doing it every alternate Saturday. So hopefully, if you're doing it next Saturday, should be able to join.
Right.
So this is the 60th week which was there. But anyway, let's come back to the topic. I'm going to use a word, okay, stewardship program. So we've been knowing about antibiotic stewardship program. I think there is a need for oxygen stewardship program right now. There is a need for steroid stewardship program currently in the COVID times. I think these two things have to be there in the hospital. There has to be somebody, some overarching person. It could be a head of the department, it could be a intensivist, it could be an ID person who needs to actually monitor how much steroids are being given to a patient. And this can be done not only in a multi-specialty hospital, but it can probably be done into a single specialty hospital as well, where isolated clinics are there. You could appoint somebody to just overlook that. Do you really need to use so much of steroids to these patients? And the stewardship program for oxygen is essentially looking at making sure that our country never ever faces oxygen problem again. We are prepared with our oxygen plan, and we are prepared with the availability of the oxygen. I can assure you that the government has done a lot in this, but it is also our responsibility to make sure that we don't waste it.
Right.
Coming to the topic of the day, the opportunistic infections. I think Subal said very well about what we need to not do. So we clearly know the things which we should not be doing, and Subal enumerated them very well. Dr. Shweta said what we should be doing. Unfortunately, that's where we are lacking. So we do exactly the opposite. We do things we should not be doing, and which we should be doing, we actually ignore completely. So that's where the human nature is a problem. And Vatsal's pearls of wisdom were really nice. You know, this virus is mutating. It's going to wear a new clothes every day. We cannot do anything about that. But what is in our hand is to vaccinate and take our masking seriously, and to keep our infection control policies seriously. I think that's where we have to be very, very cognizant of the fact. So these are my few summarizing words of this today's discussion. Off to you for the final word, Arindam.
No, mind. I will thank all of you, and I will thank HCP Forum and Alish to give us the opportunity to come together for a lovely discussion part. And we would be back probably next week. We'll inform you for the remaining concluding part of this discussion. Thank you for being with us.